Hello, please subscribe and like for our channel. Thanks very much.
So in this question, they say describe the abnormality. So here you visualize what? You visualize bowel loops. Is it clear? These are bowel loops, distended bowel loops. Is it clear? So they say describe these distended bowel loops, and it is what you are the examination that is being done here is a plain abdominal X-ray. Is it clear? Now, when you want to describe these bowel loops, you see that these bowel loops are wider than taller. Is it clear? They are wider than taller. They are central than peripheral. Is it clear? So you have distended bowel loops which are wider than taller, central than peripheral, and they are in a step ladder fashion. Is it clear? So all these characteristics plus step ladder fashion correspond to what is called valvulae connivente. Is it clear? And the valvulae connivente corresponds to a diagnosis of small bowel obstruction. Is it clear? Now you need to know that what the diagnosis of small bowel obstruction can be divided into, when you say small bowel obstruction, it can be a jejunal obstruction or an ileal obstruction. And you have to know that valvulae connivente are more in jejunal obstruction, meaning that this obstruction is a small bowel obstruction, but which is much more at the level of the jejunum. Understanding, but their diagnosis just says small bowel obstruction. Now the next question is, given that this is a plain abdominal x-ray of a 42-year-old adult, what do you think is the most probable cause? Now the most probable cause of intestinal obstruction in our context, that is low developing country, is an obstructed hernia. Don't just say hernia, but say obstructed hernia. I understand. I hope you know the difference, because we have four types of hernia, clinical hernias. The first clinical hernia is a reducible hernia. Is it clear? It can be a reducible inguinal hernia. You don't need to say if it is inguinal, if it is femoral, if it is, because all of them can be reducible. Reducible means that what? Means that when you lie down, the hernia goes back to the normal position. It goes back into the peritoneum, and when you sit up or you stand up, the hernia protrudes. Is it clear? So that is for a reducible hernia. Or you even do some maneuvers and then it goes back to the initial, it's going to go to the abnormal, through the abnormal opening. Now the second one, we have a irreducible hernia. In an irreducible hernia, what happened is that what happened is that you are not capable of reducing the hernia when the patient changes position or with those maneuvers. Is it clear? Now the next one, we have obstructed hernia. In obstructed hernia, what happened is that you have a hernia which is irreducible and there are signs of intestinal obstruction. Is it clear? After an obstructed hernia, we have what is called an incarcerated hernia. Now in an incarcerated hernia, what happened is that we have obstruction and we have occlusion of certain blood vessels, small blood vessels, particularly veins. The veins are occluded. That's why the patient starts feeling pain. Starts feeling pain at the level of the hernial orifice. Is it clear? So when you have a patient that starts feeling pain at the level of hernial orifice and that hernial sac is much more reddish, it's going to be an incarcerated hernia. And then the last one is a strangulated hernia. Now the difference between incarcerated hernia and strangulated hernia is that in incarcerated hernia we just have a small occlusion, and the occlusion is at the level of the veins only. But in strangulated hernia, the occlusion includes both the veins and the artery. That's why in strangulated hernia we have an excruciating pain. Is it clear? That's the difference between incarcerated and strangulated hernia. Generally, when you have both incarcerated and strangulated hernia, there's an emergency management. Is it clear? So now, in this case, the most probable cause in our context, Africa, is hernia. Is it clear? But now, in Europe, since they are mostly doing surgery, their most common cause are adhesions. Now, the question I'm going to ask you is, how do you classify the etiology of intestinal obstruction? Now, let us start by classifying it. So, it classified the etiologies of intestinal obstruction. You divide it into two major groups. Is it clear? We have adynamic and we have dynamic. Adynamic is also called functional, and dynamic is also called what? Mechanical. Is it clear? Mechanical cause of intestinal obstruction. Now, among the adynamic causes of intestinal obstruction, what is there? You need to know that anything that causes a local paralysis of the intestines, is it clear, are going to cause adynamic intestinal obstruction. And similarly, anything that causes systemic reduction of the peristalsis is also going to cause adynamic. Is it clear? Now, what are the causes, the local causes of adynamic intestinal obstruction? One, irritation of the peritoneum. Is it clear? Like in the case of a peritonitis, like in the case of a hemoperitoneum. Is it clear? Anything that can irritate the peritoneum is going to reduce peristalsis, like in the case of a peritonitis, which is secondary to a bacterial infection. Is it clear? You have a case of a hemoperitoneum. You have a case of a biliary peritoneum, where you have a burst of the bile duct, and then you have bile inside the peritoneum. I understand anything that is capable of irritating the peritoneum. Is it clear? You have chemical peritonitis, in a case where you have rupture of the stomach and then hydrochloric acid is irritating. So everything that causes peritonitis is going to result to the local inflammation that is going to result to reduced peristalsis. Now, for the systemic causes of intestinal obstruction, you have any systemic cause that can reduce peristalsis. Generally, you need to know that the parasympathetic nervous system causes peristalsis and the sympathetic nervous system reduces peristalsis. So in this case of systemic cause, is going to be an activation of the sympathetic nervous system. Is it clear? Generally, we have drugs. Certain drugs are capable of activating the sympathetic nervous system, like the case of adrenalines and other catecholamines. Is it clear? With other sympathomimetics, beta agonists. Is it clear? So other sympathomimetics are going to reduce peristaltic action and cause forms of intestinal obstruction. Another thing is pain. When somebody have intense pain, is also capable of having intestinal obstruction, even if the pain is not related to the gastrointestinal tract. Is it clear? That is for the sympathetic nervous system. Now, other thing like which reduce the peristalsis, we have the electrolyte level. Like in the case of a hypokalemia, hypokalemia is also going to cause intestinal obstruction, and hypocalcemia also causes intestinal obstruction. I understand. Even hypomagnesemia. Generally, symptoms of hypokalemia are actually with hypomagnesemia. Now, the next thing after that, we have visualized the adynamic causes. We can now visualize the dynamic causes. The dynamic causes or the mechanical causes of intestinal obstruction are divided into three. Is it clear? They are divided into three. The first cause, we are going to have what? The first cause we have intraluminal, the second cause we have intramural, and the third cause we are going to have extraluminal. Is it clear? Now, for the first cause, which is intraluminal, among the intraluminal causes, we have large gallstones, which are capable of causing intestinal obstruction. We are going to have bezoars. Bezoars are undigestible food products. Is it clear? When you eat undigestible food, for example, somebody start eating clots, is undigestible, is also going to cause that. Is it clear? And bezoars are divided into thyrobezoars and phytobezoars. Is it clear? So those are the different things. Now, the next thing, the third one after that, we have in worm infestation. If you have extensive worms, it's also capable of causing intestinal obstruction. We have fecal matter, fecolite, particularly in old age patients that do not go to the toilet frequently, are going to, and even patients that are having prolonged decubitus. Generally, when patient tells you that he has pain in the abdomen and is not defecating for a long period of time, that is because and his prolonged decubitus, you have to always do a DR in order to remove the fecal matters. Is it clear? Other patients that have it, you have patients with spinal cord compressions. Is it clear? They are also going to have the intestinal obstruction as a result of fecaloma or fecolitis. Is it clear? So generally, those are the things that you have to know. Now, the next thing after that, you are going to have intramural. Among the intramural causes, you have intussusception, which is the invagination of the bowel wall into itself. You have the volvulus, which is the twisting of the bowel wall around its mesentery. You have the next one, which is what after volvulus. Those are the generally those ones are instead the intramural, yes, the intramural. We have also Crohn's disease, is it clear? We have ulcerative colitis, and we have the TBMT, tuberculosis, is it clear, of the intestine. Now, for the extraluminal, is it clear? For the extraluminal, among the extraluminal now, we have adhesions. Is it clear? Just sometimes people put intussusception and volvulus among the extraluminal. Sometimes they put among the intraluminal. It depends where you want to put it. Is it clear? Now, for the extraluminal, we are going to have things like number one, we have adhesions. Number two, we have hernia. And hernia and adhesions are the most common cause of intestinal obstruction. Hernia is the most common cause of intestinal obstruction in our context, and adhesion is the most common cause of intestinal obstruction in developed country. So generally, those are what we have on intestinal obstruction.